get some more people in our audience. All right. So I think it's just half a minute or a minute past the time, and let's get started. Greetings, everybody. My name is Hardeep Singh. I'm a professor and a healthcare quality researcher at Baylor College of Medicine in Houston, Texas, in the U.S. I'm delighted to welcome you to this webinar about rethinking the use of plastics in healthcare. One of the reasons I'm here is Healthcare Without Harm is one of the co-sponsors of this webinar, and I've been actively working with Healthcare Without Harm for the last a year or so on several plastics initiatives. In the last CleanMed conference that they had in May, there were 6 sessions on plastics. So you can see the increasing interest in the healthcare and sustainability arena on the use of plastics. Now, this webinar has been inspired by a new report by Eunomia and Systemic, a report called Prescription for Change, and absolutely, it's time for change. And this report highlights not only just the impacts related to waste, costs, and emissions, but also proposes solutions, which is what we need for this area. So why is this report so timely? Let's go to the next slide. There's several reasons why. I want you to look at this picture, which is made by a Dutch artist who was going to have a double mastectomy, and she told the surgeons to give her all the supplies that were used during the surgery, and she made a visual art out of it. And you can see that there's a lot of things in here, and there's a lot of plastic, and that is from one surgery on one patient. Now, the numbers are very alarming. We have a lot of plastic waste from mostly single-use plastic from U.S. hospitals. Huge supply chain impact. There's also this lack of awareness in healthcare. A lot of the physicians and clinicians that I talk to, they actually don't realize that 98 to 99% of the plastic products are coming from petrochemicals. And all of this use of plastics and the waste is contributing to emissions and cost as well. Now, there's a lot of literature coming out on the chemicals that are released from these plastics, which can cause infertility, congenital disorders, and increased cancer risk. And recently, a few years ago, there was a study in one of our top journals, the New England Journal of Medicine, that showed there was almost 4 times the risk of having a death from MI, stroke, when you had microplastics in your carotid. So again, the risks are becoming quite alarming in health and healthcare. So let's go to the next slide. Now, anytime you think about the problem and you want to understand how do we go around reducing the use of single-use plastics in healthcare, I mean, easy thing to do would be, hey, can the clinicians just use less of them? But it's not that simple a problem. We need more research. We need our healthcare organizations to sort of support the way that we are doing things. So what we did was last year, we proposed a socio-technical lens to understand this problem of reducing plastics in healthcare, as well as proposing some solutions, which go all along to not just the technical things, such as better materials, less maybe use of more things like bioplastics or more sustainable plastics, but also creating a circular infrastructure, having policy reforms that incentivize some of these things that we are trying to get to, and most important, culture change. We don't need to be wearing gloves all the time to examine patients who don't even have any contact precautions. And we see that off and on when we examine patients that people are wearing gloves, and we never used to do that. So there's a lot of culture change that needs to happen, along with more research and data needs. Next slide. So any solutions to the problem have to be proposed along what's called a value chain of single-use plastic products. So that starts from production, distribution, use, recycling, as well as disposal. And there's many people, many stakeholders who are involved in this value chain. And that's why this is an important systemic problem to solve and requires shared responsibility across all of those people who are involved. And this report really will build upon some of these general principles about how to approach single-use plastics. And I'm now going to turn over to Yoni to take it from here to talk about this report in more detail. Yoni, over to you.
Thank you, Hardeep. Thank you so much. And thanks to all of you for joining our webinar today and taking time off your very busy calendars. I'm delighted to be here today to present a prescription for change. The team has been working for months and waiting for this moment. So I'm very excited to be here. My name is Yoni Shiran. I'm a partner at Systemic. For those who don't know Systemic, we are a B corporation whose mission it is to work on the system changes needed to achieve the UN Sustainable Development Goals, as well as the Paris Agreement, with a particular focus on the circular economy. And it was our great pleasure to work with Eunomia on this project, who are also a mission-driven company, and Pallavi will tell you more about their work later today. So why did we choose the healthcare sector? I think, as Hardeep was saying, healthcare has been largely outside of most conversations around circularity and around decarbonization to date. I think if you look at major policies such as SB 54 in California, such as the packaging and packaging waste regulation in Europe, and in many other places across North America and Europe, to a large extent, healthcare has been exempt from many policies. But also, if you look at NGO, activist NGO campaigns, many of them have left out healthcare, mainly because there's such a sensitivity around patient health and patient safety. But we thought that given that healthcare is one of the most plastic dependent sectors, where the growth of single-use plastic has been tremendously fast in recent years, and there is a sector where there actually are very good solutions. Hardeep in his opening remarks alluded to a few already. In the report, we talk about many others, and I'll share some of those with you today. But given there are solutions, and given that under BAU, the sector is really kind of not on a great trajectory, both from a single-use plastic perspective, but also from an emissions perspective, we thought it was important to focus on the sector. And it's not for nothing that Healthcare Without Harm recently published an open letter asking for a phase out of harmful and problematic plastics in the healthcare sector. This open letter has been signed by over 48 million healthcare professionals from around the world, asking the healthcare sector to be part of the debate on solutions for single-use plastic and to be part of regulations and so on. So that is the overall context of why we did this work. It is the first full system study looking at the healthcare system, kind of plastic use within the healthcare system, and understanding not just the baseline situation and the business as usual scenario, but more importantly, what are the solutions out there and what are the economic, environmental, and social implications of those solutions, of course, without compromising patient safety, patient health. That is, of course, the top priority for the healthcare sector. We've had this pleasure in this work to work closely with a distinguished expert panel of scientists and academics and practitioners in the healthcare sector who validated the approach and the work and the underlying model and the results I'll show you today. So I just want to quickly thank our panelists. That includes Professor Mahmoud Bouta from the Brighton and Sussex Medical School, Jason Fisher from Houston Methodist, Liam Hogg from NHS England, Dr. Nicole Hunfield from Erasmus University Medical Center, and last but not least, Dr. Rachel Meadow from the Rice University's Bacon Institute for Public Policy in Houston. You'll have an opportunity to hear from Jason and Rachel more later today, who will join our panel. So when we talk about a prescription for change, I think I want to walk you through 4 critical questions, which are at the heart of the work we've done. The first is, where are we headed if no significant action is taken, and what is the cost of inaction? Number 2 is, what are the practical solutions and what is their impact from an economic, environmental, and social perspective? Number 3 is, what is blocking progress today? And number 4 is, what will it take to achieve system change? So first things first, let's start with where are we headed? And I think for this, it's important to understand that across North America and Europe, there are 7 product categories that make up the vast majority of single-use plastic consumption in healthcare. And so naturally, our work focused on these categories. You can see them on the screen. So we have fluid bags and tubing, 23% of overall volumes, gloves, 21%, rigid devices, 15%, device packaging, 14%, PPE, 11%. Obviously, this category has grown a lot with COVID, and many of the volumes have stayed also after COVID. That's true across all categories, but specifically for PPE. Wipes, 8%, and pharmaceutical packaging, 8%. So these are the 7 categories that we focused on. We focused on North America and Europe for the quantification, even though we've looked also for case studies from around the world. And what we found is that today there's a staggering 2.1 million tons of single-use plastic used in the healthcare sector across North America and Europe. That translates to 9.3 million tons of CO2 from greenhouse gas emissions. Most of these emissions are in the upstream, so in production of these fossil-based plastics, but also in the incineration, which is a very common practice in Europe. And the total cost is estimated at $56 billion per year, again, mostly paid by governments and by taxpayers in a time where there's obviously a lot of pressure on fiscal budgets as it is. If you fast forward kind of under a business as usual scenario, if we keep the system as it is today, we expect the situation to only get worse. And you can see here the numbers on the slide, but BAU is expected to see around 2.9 million tons of single-use plastic by 2040, 12.9 million tons of CO2, $76 billion of total system cost. So across all the main indicators, the situation is getting worse, with a growth of between 35 and 40%. So this is a scenario that I think none of us wants, and we need to think strongly and creatively how to avoid. And that's exactly what this project was about, is looking for solutions, circular solutions that can offer an alternative path to the system. Because put simply, without systemic change, the negative impacts of single-use plastic in healthcare will become more severe, will put more pressures on public budgets, on waste streams, and on climate outcomes. So what are the practical solutions and what impact could they have? I think the good news is, despite what I just showed in terms of the business as usual trends, the good news is that there are solutions, circular solutions, that are proven and can be effective, again, without having negative impacts on patient health. In this study, we've bucketed these solutions across 5 main categories, as you see on the screen. The first one is around refuse, rethink, and reduce. So these are any solutions that can reduce the total amount of plastic waste in the system by phasing out unnecessary products or components, such as redundant layers of packaging or overused equipment or items like gloves, as Hardeep was telling us earlier. Reuse includes shifting to durable, sterilizable alternatives, such as reusable gowns or metal trays. Substitute materials includes changing to alternative materials, including paper, where that makes sense. Improving recycling is a very interesting one. This does require better design, so starting all the way upstream, better segregation, better collection. But we do think that even though today recycling of plastics in healthcare is essentially non-existent, we do think that with the right interventions, it is possible to scale these solutions, and we'll give a few examples in today's webinar. And then last but not least, procuring low greenhouse gas emission plastics, which do exist out there. And our analysis showed, our modeling shows that if we combine all these solutions and we scale them across North America and Europe, there is a potential to reduce single-use plastic in healthcare by approximately 53%. You can see how it breaks down across the different solutions and the different plastic categories, but the biggest opportunity is around refuse, rethink, and reduce, as well as reuse and some of the categories that have the biggest numbers are gloves and fluid bags and tubing. To bring these reduction potential, this opportunity to life, I want to take you through just 2 case studies to highlight kind of the potential. So the first one is a campaign called Glove Smart that was rolled out in St. Paul's Hospital in Vancouver. Obviously, during COVID and after COVID, there was a big surge in use of gloves in hospitals. In this particular ICU, they had 33,000 gloves being used per month. And the staff of the ICU, together with the hospital's waste working group, launched an education-based campaign to reduce inappropriate glove use, which resulted in a 53% reduction of glove use over 6 months and over 2 tons CO2 reduction. And the audit score, interestingly enough, increased the audit score for correct use of gloves, according to the guidelines, increased from 39% to 75%. You can see on the picture on the left, the staff at the hospital exposing their hands, their glove-free hands. So that was one case study. And the second one is from Northwestern Memorial Hospital in Chicago. IV bags obviously are a major source of non-hazardous plastic waste in hospital. And despite the fact that they're non-hazardous, most of them end up in landfills if it's in North America. And through this intervention in the hospital, they're able to collect and recycle these non-hazardous PVC IV bags, turning over 5 tons of single-use plastic waste, diverting that from landfill, and turning these volumes into industrial products such as floor mats and dock edging. So these are 2 examples. There are dozens of other case studies, which we've highlighted some of them in our report. And the idea is that if we were to take these case studies and really scale them across the system, across all the hospitals, that is the opportunity that we're excited about, and that's what we've modeled in the work, and of what would be the impact of doing that. Of course, we've looked together with our expert panel. We've looked at the potential of which of the solutions are relevant for the different categories. So we've been very thoughtful about applying this at scale. But I showed you earlier the impact from a single-use plastic reduction perspective. Here you can see on the slide the impact from a greenhouse gas emissions perspective. So we're talking about a 55% reduction of greenhouse gas emissions. Again, if we were to scale all solutions, all known solutions across hospitals, you can see the biggest impact on greenhouse gases being from refuse, rethink, and reduce on the left, as well as procuring low greenhouse gas emission plastics on the right. That would obviously have a big impact on greenhouse gas emissions. From a cost perspective, similarly, we would see a 24% reduction in the cost of single-use plastic in healthcare, even after accounting for the increased cost of some of these interventions, including procuring low carbon plastics, which do cost more than virgin plastic. So this is in terms of what is the opportunity. To summarize kind of the results, under a high ambition scenario, we could see single-use plastic decrease by 53% to 1.4 million tons. Again, this is across North America and Europe. Greenhouse gas emissions decreased by 55% to 5.8 million tons, and decreased by 24% to $58 billion. If we put the scenarios side by side to compare them, you can see that across all 3 metrics, the high ambition scenario is more attractive than a business as usual scenario by 2040. So if this high ambition scenario is so attractive from all these perspectives, why is it so difficult? Kind of what is stopping us from really achieving it and really implementing this at scale? What is really blocking progress? So in this work, we've identified 7 major barriers that are really slowing down the transition to a circular economy in the healthcare sector. The first one is about fragmented and siloed governance. So we've seen, for example, in one hospital, they were buying eco-friendly syringes with recyclable packaging, but because the procurement team and the waste team, in that hospital had not sufficiently aligned, those eco-friendly alternatives were still being sent to landfills because the right system wasn't in place to make sure that we have the right infrastructure and the right systems, and that can be addressed by having more cross-functional teams and trying to break down some of the silos in governance that sometimes happens in healthcare systems. Second is around data gaps and lack of transparency. I think, needless to kind of to state the obvious, having better access to data, reliable data, can help hospitals and healthcare systems make better decisions, which will ultimately lead to better outcomes. The third is around short-term cost over life cycle value. So in one example, in the Manchester University NHS Foundation Trust here in the UK, they're able to cut emergency drug waste by 84% by shifting to pre-filled syringes. And what they found out is that even though the cost of the pre-filled syringes are more expensive relative to the normal syringes, over the life cycle, if you take a full system perspective and over the life cycle and all the operational costs that you save later and the end of life costs that you save later, these syringes end up being more cost effective. So I think it's important for healthcare facilities and hospitals to always take a full life cycle perspective when making these procurement decisions and not just looking at the procurement cost upfront. Regulatory inertia and misaligned incentives, clearly important. We need to see policies that are creating incentives for circularity within the healthcare sector. Just like we see that in other sectors, we need to make sure that those policies, where applicable, where relevant, also apply to the healthcare sector. Infrastructure and investment, of course, we need to make sure that hospitals have separate bins to collect things that can be reprocessed. The right collection systems need to be put in place. The right recycling systems need to be put in place to deal with the very specific waste streams coming out of healthcare settings. But we think these things are possible, and pilots are already proving that these things are possible. Of course, we need to complement that with behavioral norms and with addressing market failures that sometimes send weak demand signals. We spoke with one of the recyclers asking them, why don't we recycle more healthcare plastic? And they said, of course, we have the technical ability to do that. And of course, we want to do more of that. But if the hospitals are not separating the stuff or not sending us things to recycle, then of course we can't invest into these recycling plants. So it's a full system approach that needs to be delivered and built to ensure that the healthcare system can shift towards circularity. And this brings me to the final question of what will it take to achieve system change? Because what we've shown here through the examples we gave is that the technical solutions exist. We know how to do some of the stuff and we can scale these pilots. It's all a matter of having appropriate policy frameworks, the right incentives, the right funding mechanisms, and that is what will be required to have real system change. So we've broken down this kind of, when we think about, yes, we need decisive action from all stakeholders in the system, and we need stakeholders to work together. We've devised this framework that essentially summarizes the main actions and activities that will need to happen to enable the circular economy transition in the healthcare sector, or at least acceleration of it. And the four buckets are, the first one is around creating an enabling environment. B is around establishing multi-stakeholder transformation bodies. C is delivering system transformation projects. And D is transforming finance. And for each of these, we've spelled out in the report what exactly would be needed and what is the role of different stakeholders to really bring this to life. But the first bucket around creating an enabling environment is really around policy change and behavior change. Establishing multi-stakeholder transformation bodies includes things like making sure we have the right data, building shared data sets to guide action, to guide investment, making sure we have sector-wide strategies and targets, and clear sector roadmaps. Delivery system projects includes things like investing in procuring low carbon emission plastics. We know these solutions exist. We know they're starting to scale. Yes, sometimes they're more expensive, but the more we scale them, the more they're going to drive down the cost curve. Also, circularity projects, reducing unnecessary consumption and scaling reuse and enabling innovation. We've seen some examples of case studies. Again, there's many, many more in the report. These things can be delivered if we focus on them. And then finally, Finance, of course, is important in any kind of system transformation. So we need to fund infrastructure to deliver these solutions, and we need to fund innovation to deliver these solutions. So it's not going to be easy. Many things need to be done. A lot of collaboration is needed between the actors. But an important message here is that solutions are possible because technical solutions do exist. It's about creating the right environment to enable them and to scale. And so the main message I want to leave you with is we don't have to choose between patient safety and sustainability. Through the analysis that we've done, we've shown that you can do both. You can scale solutions that will reduce cost, reduce volumes of plastic, reduce greenhouse gas emissions, sacrificing or jeopardizing patient safety. And I do invite all of you to download our report. You can see it on the website to have the full story. Thank you so much. I hope you found that useful. With that, I will now pass it on to my colleague, Pallavi Madagasira, who is the managing consultant at Eunomia, to introduce herself and the panel. Pallavi, over to you.
Thank you so much, Yoni, and welcome again to our panelists and to the audience. We're really excited to jump into the panel discussion here. Just to introduce myself, I'm a managing consultant at Eunomia, and where I work at the intersection of policy, innovation, and finance to advance circular economy solutions across a plethora of industries, including healthcare. And for those of you that don't know about Eunomia, we're a consultancy focused on accelerating the transition to a circular, decarbonized economy by working with governments, global brands, investors, and NGOs to align policy, infrastructure, and innovation. So we've just heard, in case you were just joining us, we've just heard from Yoni and also during the opening from Dr. Hardeep Singh that going about as business as usual is clearly not an option. And that if we don't act by 2040, everything from the plastic waste, greenhouse gas emissions, and costs in healthcare could grow by up to from anywhere between 35 to 40%. Dr. Singh also reiterated the need for a multifaceted approach to tackle the issue of the use of single-use plastics in the healthcare industry. So the key questions for us right now are what's holding back adoption? What enabling conditions could accelerate the progress? And what does success look like if we were to fast forward 10 years ahead or even 20 years ahead? So I'm really thrilled that we have a diverse panel with us today, from health policy and clinical leadership to sustainability and regulatory expertise. As a reminder, before I introduce the panelists, the audience should use the Q&A box to drop your questions. Please do not use the chat function, and we will take questions throughout the panel discussion, so feel free to type away your questions. And without further ado, our first panelist is Jason Fisher, who, after a diagnosis of a blood disorder, endured a stem cell transplant and recovery from bone marrow failure that inspired a career in healthcare. With a background in organizational leadership development and nonprofit management assistance, Jason pivoted into healthcare and joined Houston Methodist, the Woodlands Hospital, establishing their environmental services and patient transportation departments, as well as developing a network-wide environmental services council of directors. Jason joined the Houston Methodist Academic Institute to develop the Office of Sustainability for the hospital network to aggregate sustainability efforts while aligning projects through innovation and conservation in support of health, well-being, and research. Rachel Meidel is our next panelist, who is a Deputy Director and Fellow at Rice University's Baker Institute for Public Policy Center for Energy Studies. Her research focuses on sustainability, circular economy, life cycle management, and understanding the economic, environmental, and social impacts across supply chains. Dr. Meidel was previously appointed Deputy Associate Administrator of the Pipeline and Hazardous Materials Safety Administration in Washington, D.C., and has nearly 30 years of experience in industry, academia, government, finance, and international relations. Dr. Meidel is a certified hazardous materials manager and received her PhD in law and public policy from Northeastern University. Our next panelist and expert is Mr. Ted Shetler, who is the Science Director of the Science and Environmental Health Network and Science Advisor to Healthcare Without Harm, an organization seeking to reduce adverse public health and environmental impacts of healthcare institutions. He has a medical degree from Case Western Reserve University and a master's in public health from Harvard University. He is the author and co-author of a number of reports, book chapters, and journal articles addressing a variety of topics related to environmental health. He has served on advisory committees of the US EPA and National Academy of Sciences. And finally, we are joined by Dr. Hardeep Singh, who also opened the webinar. And in case you missed his opening, Dr. Singh is a professor at Baylor College of Medicine, Houston, and leads a portfolio of multidisciplinary quality and safety research. His work has informed several national and international quality and safety initiatives and reports, including the National Academy of Medicine, CDC, WHO, and the White House. Thank you, panelists, for joining us today. And let's just jump into the discussion. So I guess to start off with, I'm going to maybe pose one question to each of you or to all of you. So I'm going to maybe tag Dr. Singh to start it off with. What do you think is holding us back or holding back the adoption of circular practices in healthcare today? I know we've published the report. You've looked at it through your own research and effort. Is it technology, economics, culture, or is it something else?
I think, Pallavi, it's literally all of it. And I think the most important thing that's happening is competing priorities. If anyone knows healthcare well, you know, we always have some fire burning that we are trying to put out. There's always some kind of other competing priority that we're dealing with. We were dealing with COVID, now we were dealing with workforce issues, financial issues. I think if you can get the leadership buy-in of a healthcare system per se, that would be a good start. We really need to get clinicians motivated as well. As I was talking in my opening remarks, we don't have a good, a lot of the clinicians don't actually understand some of the implications and ramifications of all this plastic waste, even though they see it, but they don't know what to do about it. So we got to like empower them. And I think policy changes are gonna have to happen for this to succeed. There are incentives that we could put in. We've actually spoken to manufacturers as well who sort of attest that if we had the right incentives, we could get the hospitals to buy our much more sustainable products, but we don't do that. And even some of the basic things that are in the report, such as reuse and reprocessing, we just don't do that very well. A lot of the hospitals are not doing basic reuse and basic reprocessing. So I think there's a lot of things that are holding us back, and which is what the shared responsibility concept that I was trying to illustrate earlier, that we're going to need to work on. We almost like need a plastic czar, at least for America, that we can sort of say, you know, the healthcare plastic czar that can actually take actions on a unified front.
Thank you, Dr. Singh. I'll turn it over to Rachel.
Yeah, I agree with everything that that Dr. Singh has mentioned, as well as the great summary by Uni. And what's holding back circular plastics and practices, in my view, is really everything, right? The adoption is held back by a mix of regulatory, market, cultural barriers. There is regulatory fragmentation, which creates a lot of uncertainty and inconsistencies, and that makes it really difficult for companies to invest confidently because definitions of, for instance, recyclable or waste vary across jurisdictions, they vary across statutes, and vary across regulations. There's also economic disincentives, including low virgin resin prices, the lack of stable demand for recycled content, and procurement practices that prioritize the lowest upfront costs. And that undermines the business case for circular solutions. And then we also have infrastructure and logistical gaps that limit feedstock aggregation, transportation, and processing at scale. And at the same time to all of this, the standardization challenges around quality, traceability, recycled content create inconsistent market signals. And so finally, a lot of this boils down to behavioral and organizational inertia, and also risk aversion in healthcare. limited awareness in circular benefits and the entrenched supply chain contracts. All of this slows experimentation and uptake in order to get to circular practices.
Thank you, Rachel. I'll turn it over to Jason and then Ted.
Yeah, thank you. I would agree wholeheartedly. I think looking at the value stream, across the value stream, especially from an operations standpoint in the hospital, when we look upstream, the products that are coming into the hospital, making sure that it's aligned to make it as feasible as possible for our clinicians without loss of efficiency, to be able to process and sort and provide the system to be able to recycle those items is extremely important. Making sure there's a reduction of mixed polymer items to be able to really aggregate and get the volumes that we need for the downstream markets that are looking to purchase our recyclable materials. I think that's another piece of that is looking at, the aggregation of the amounts of materials that we have, and looking at one hospital or one hospital system may not be able to meet those demands of 500,000 pounds a month. So how do we develop regional networks and those regional partnerships to be able to aggregate that and work together to realize those opportunities for the end market?
Thank you, Jason. And Ted?
Well, the only thing I would add to what has already been said is that I don't think there's a real appreciation of what the health and environmental consequences of this activity are. And while we're thinking about the challenges, I think we need to make clear that there are real health consequences that people who are making these decisions need to understand and then confront.
Thank you, Ted. And maybe I'll actually build off of that. And I'll start with you, Ted, this time. For those that perhaps are a little misinformed, to Dr. Singh's point, or others that perhaps don't fully understand the implications of making these decisions or not, what evidence do we really have that reducing plastic use in healthcare is in fact likely to reduce environmental impacts through product life cycle and improve patient and community outcomes?
Well, replacing single-use plastic products with similar products that are made, as we've heard, of durable or reusable material will reduce patient exposures to hazardous chemicals that leach from these plastics during their use. Exposure levels to hazardous chemicals that are in these plastics from repetitive use or from multiple products can increase the risk of adverse health outcomes. And when plastic products are essential for patient care, choosing safer alternatives made of different materials can also reduce exposures to hazardous chemicals. For example, replacing polyvinyl chloride plastics that are made soft and flexible by the addition of a plasticizer, often a phthalate is used, but replacing those with a different plastic polymer will demonstrably reduce patient exposure to the hazardous plasticizer that leaches out of the product. Similarly, community and public health can be improved by reducing exposure to hazardous chemicals and pollution throughout the plastic life cycle. For example, hazardous air and water emissions from plastic manufacturing facilities where workers and people in the nearby communities are exposed. And similarly, hazardous chemicals released from plastic products disposed in landfills or burned in incinerators contaminate nearby water and air, and people living near these facilities can be exposed, increasing their risk of adverse health outcomes. And finally, I would just pick up on a thread that was started earlier about we're increasingly aware of the health impacts of microplastics and so-called nanoplastics, which are tiny pieces of plastic and their associated chemical additives, which are often invisible to the unaided eye, that come from the chemical and mechanical breakdown of plastic products during their use or after disposal or recycling. And in recent years, we've learned that microplastics contaminate virtually all ecosystems throughout the world and are present in virtually all people and wildlife. and their adverse health effects are just now beginning to become apparent, including a high likelihood that they are contributing to observed increases in several kinds of cancer, cardiovascular disease, as was mentioned earlier, and others. So there are a number of health consequences of this plastic use in healthcare that I think we need to raise up as a major driver for the change that this report outlines.
Thank you, Ted. And if I can just build on that, and this is a question to both Dr. Singh and Jason, from inside a major research or medical institution, what practical challenges or misconceptions do you think sort of have, or have you observed, slow down the adoption of sustainable materials and practices? I know we've already talked quite a bit about the several different levers we can certainly implement, but be curious to get both your insights on what does it look like from inside a research or a medical institution and your views on that. And Jason, do you want to? Yeah.
Sure. Yeah, I think, going back to this piece on education and making sure that your constituents really have an understanding, again, of the health effects of the impact from a resiliency perspective and what can be done. I think that's the foundation that we have in healthcare and really laying the path forward for adoption. When we look at the barriers across a large organization, 35,000 plus employees, making sure that you recruit your champions, you find those that are passionate, and making sure that you target and don't bite off too much at once. I know that from my perspective, sustainability is such a wide encompassing idea and practice. And so making sure that as you're going forward, you're really targeting in on the low-hanging fruit and the biggest impact areas, and making sure that you're educating those individuals that are out there practicing and those individuals that will be the future leaders to be able to lead in the effort and to advocate across the hospital system.
Dr. Singh?
I would add, I think incentives is a big one, and pricing. So a lot of the single-use stuff is cheaper. I mean, there's talk to the procurement people, say, well, why would we buy something a lot more expensive, even though it's sustainable, because it doesn't give us our, return on investment, and the business case for doing that isn't existing. A couple of years ago, we were having a session at CleanMed meeting where some of the manufacturers spoke up and said, all the market forces are misaligned. We're trying to get products into the hospitals and trying to get them to buy these materials, but the hospitals are saying, too expensive. You are not as economically as better as the others. Now, I must also add, while I think that's an important one, we do need better data. We haven't talked enough about research and data and evaluation. A lot of these products that are being sort of made, whether it's bioplastics or whatever sort of these new materials that are coming out, they should get rigorous evaluation to make sure that they are better and safer in every way and more sustainable. So we're going to need a lot of research. And right now, I don't see a lot of research in this area happening, at least sort of in the healthcare world. And we're going to need that. We're going to need that data.
And can I add to that too? I just want to underscore what Hardeep just said about the need for data. I mean, that is critical in understanding all of this and for achieving circularity, and also in understanding trade-offs and risk shifting. And one thing I want to go back to is that this study, a prescription for change, is a systems level approach, and that is very important in understanding sustainability and to look across the entire system, right? Because when adopting a systems level approach, we have to consider the entire life cycle. It forces you to think holistically across a broad range of impacts of environmental, social, and economic spectrums, right? And this is because some pathways or presumed solutions could inadvertently introduce new risks or shift risks elsewhere across the value chain and create unintended consequences elsewhere in the system. And so the focus must not just be on ensuring that a new material or presumed safer material is better, but that it meets rigorous product performance and safety standards and is also considered sustainable, low carbon, all these other things. But in doing so, balances those trade-offs and manages those risks across the entire system. And I want to give just a very common example here to help you understand that. But think about bioplastics. They're presumed to be lower carbon and renewable because they're plant-based, but they can also compete with food crops, deplete arable land for farming, constrain water supplies in already drought-stricken regions of the world, where these base materials are sourced. And so this exacerbates like food, water, energy crisis in disadvantaged communities. So my point here is that we have to understand the entire picture and keep in mind that this is a systems-based approach, and there's always going to be trade-offs. There's never just one solution. You're going to have many trade-offs. So it's really important to look at the entire landscape from the full life cycle across an entire globally complex supply chain, which is a challenge.
Well, we've talked a little bit. I think there was quite a few wonderful and important things you talked about the need for better data and better research and validation. And then there was the piece around how do you balance the need to run on tight budgets, because not all hospitals are large systems and they run on tight budgets, while also balancing the need for strict compliance, while also understanding all these trade-offs. So I just want to tease those two apart a little bit. And maybe I'll start with you, Rachel. How do you make the business case internally for change, especially when you're trying to consider procurement practices that are inherently leaning more towards the cheapest cost options, and then recognizing that making one change isn't necessarily going to have zero trade-off. So how do you make the business case internally? And then once you're done, I'll pass it over to Ted and Dr. Singh.
Okay, and I guess I'll be brief in this. I mean, for me, it goes back to data, high quality, consistent data, and a lot of this goes back to understanding the flows, the plastic flows. So we need data on the types, the volumes, and the fates of all plastic chemistries used in healthcare, even across other sectors, because plastics just don't flow within the healthcare space, right? The entire plastics economy is multi-sectoral. And so there's really limited visibility into what proportion of plastics are used, recycled, how much is actually recovered, or even just looking at the carbon or toxicity footprints across different pathways. And so understanding this helps us make better, more informed decisions. And even things like data on microplastics exposure in a medical setting and on the economic cost of linear versus circular systems. Like this is so fragmented. And so greater transparency and more data on material flows, contamination rates, infrastructure capacity, and life cycle impacts will ultimately in the long run help make better, more informed decisions.
Let me turn it over to Ted. Do you want to build on that, Ted?
Well, the only thing I would add is to just reemphasize this misalignment of incentives that was previously mentioned, because the health consequences of this at not only the patient level, but also to community and public health level are externalized. They don't show up in the hospital budget. So it makes sense if you're working within the healthcare system that you would say, but why would I spend more money on something that might be safer? I mean, it doesn't, the business case isn't there unless you start looking at these externalized costs.
Jason?
Yeah, I think when we look at this internally, that I'll lay the foundation with three basic ideas. The case for health and well-being, as Ted has talked about, really looking at extreme heat, cardiovascular disease, and kidney failure, looking at flooding and the leaching of materials into our soils and our communities, really diving into air quality and respiratory, cardiovascular disease and allergies and microplastics, and understanding the emerging health impacts from microplastics. The other key aspect of this is really the case for employee engagement and understanding that we have such diverse and diffusion of cultures, and there's a demand for this from employees and from our physicians, and there's an interest in there, and being able to serve that to create a culture where employees want to come and work is extremely valuable to hospitals, to our research centers. And then last, the case for resilience, really looking at, from a quality and performance improvement perspective, how do we hedge against international resource and supply disruptions? We see it continuously, more recently with IV bags and the resulting conservation that's come out of that, and how do we take those lessons and apply them before a disaster hits? Value creation for healthcare industry that grapples with those financial constraints, understanding how this is going to be more viable in the long term, and really last, that community and environmental health resilience, and how are we taking care of the communities that we're serving? How are we not contributing to the diseases that we're treating in our hospital walls?
Great. Dr. Singh, do you want to add to that?
So I mean, a couple of things I was thinking. I think all health systems, all hospitals need to have Jason Fishers. And they need to have multiple Jason Fishers and Jason Fishers with their sustainability team. And those sustainability teams need to identify the hotspots where we can get that business case, the places that are not the highest impact for cost, waste, harm. We don't have that right now. Most hospitals in the US don't have dedicated sustainability teams that are looking at single-use plastics, where we are absolutely wasting this. We are costing a lot of money, but we don't do anything about it. So we need a dedicated. And actually, funny thing is, a lot of the clinicians I would speak to, they said, "Wait, you have a sustainability manager in our hospital?" And the sustainability people that I talk to say, "Well, the clinicians don't want to talk to us about stuff." And so, we need a better integration. I know that Jason and his team have been trying to do that, a better integration between sort of the sustainability people in the hospital at one end, the clinicians on the other, so working together to come up with what's the best case, where are the hotspots, and let's work together to fix that. The second thing I was thinking, when sort of the health impacts and the community things that Jason and Ted were also referring to came up, I think at some point of time, Jason brought up employees, but at some point of time, I think we're going to need to engage patients. We're going to need to tell patients how much harm this plastic is getting. And there's a lot of these headlines that keep coming out every day now, like microplastics everywhere. Now every layperson I talk to, they say, "Oh, what's this microplastic thing? Should I be worried?" Yeah, you should be worried. But we don't speak to them about how to engage them in this conversation around, can we empower you to put pressure on the hospital and the health system that you go to, and to ask them, why are we wasting so much? I actually was talking to a patient the other day, and they said, "I went to the hospital just for the ED visit. They put the pulse ox and a couple of other things they were using, and they just trashed the pulse ox meter immediately after they used it on me." Why would they do that? Right? When patients get engaged to ask questions to the hospital leaders, why are you sort of wasting so much money? I think the hospitals will have to get sort of, on board with this. That'll be a nice business case, in addition to the usual incentives. Joint Commission hasn't come up, but I would sort of also mention that I think if people like Joint Commission and all the other accrediting agencies put pressure on hospitals to sort of do things that are making more sense, that itself will start making the business case. And we've learned that in patient safety. You got to give them some incentive to do stuff.
Absolutely. And I'm just looking through, oh, go ahead, Dr. Rachel.
I just want to add one more thing to that, is that another thing that is critically important here is carefully scoped and tailored life cycle based assessments and supply chain mapping to identify where those impacts and hotspots are. And that ensures an accountability mechanism as well. Things like supplier standards, certification schemes, transparency requirements, all built into procurement and end-of-life practices, whether that's product stewardship or extended producer responsibility principles and practices. All of those things could help ensure accountability.
Thank you, Rachel. And it looks like a lot of some of your responses are already in response to the questions we're getting from the audience. And I'm going to jump to this one question that we have from the audience. Do you have any practical recommendations on how we can maximize collaborations with IPAC to advance sustainability and reusables, especially given their instrumental role in the process? I don't know who wants to take that question. Is it Jason? Do you want to jump in?
Sorry, could you repeat that?
Yeah, do you have any practical recommendations on how to maximize collaborations with IPAC to advance sustainability and reusables, given their instrumental role in the process?
Yeah, I think, when we look at collaboration for our organization, I think laying the foundation of what's most important for your organization. Every organization is going to have a different focus, but really understanding what it is that your audience and your stakeholders want to address most importantly, and being able to find the right partners to really develop on that and reach out and find a pathway that you can collaborate. I think there's no shortage of individuals that aren't willing to say yes. How can I help? I think it's just a matter of reaching out, making those connections, especially those lesser known connections or those acquaintances, making sure that you develop out those relationships to really seek a way to work together that provides for each other's needs along the journey.
Great. I know we have only about 5 minutes or so left in the webinar, so maybe if we could just jump forward to the future, I'd love to get each of your sense on if we were in 2030 by now, or even 2035, what would each of you look back to say, this is a good enough measure of success? Or what would success look like for you if we were to accelerate 10 years forward, considering all the very many constraints and the trade-offs that we've discussed? And I guess I'll start with Dr. Singh on that.
Slide, because I thought something like this might come up, and I have a hidden slide. We just recently proposed a framework to help health systems use a very pragmatic approach to try to figure out what they should work on. And I think, can anybody, Joanna, or do you have the access to the slide that I had kept? If you can project that, I can walk through the framework. If not, I'll just tell you about the framework. It's basically a pragmatic framework for streamlining the use of single-use plastics. And it has 3 categories. One is categories of things that, make sense. There you go. When there is no conflict with patient safety, no conflict with affordability, no conflict with effectiveness. These are the things we should do right away. It's the yes, we can category. And there's multiple examples. All the things that we do in high value care, there's lots of low risk single-use products that we should be switching. We should be doing these things right now. Don't have to wait. And hopefully things will get better in 5 years. The second is the context-dependent category. That's the one that, hey, we need more research. Remember, we were talking about let's do more research and let's get more data. The second category of sort of this, what things we should work on in the next few years, is in that category, where we need to explore more. We need to have a conversation. Somebody mentioned about IPAC. I'm assuming we were talking about infection prevention folks. And, there's a lot of things we need to talk to them. There are a lot of areas of debate. Somebody's going to have to research and study them. And then the third category is no category. Heck no, we're not going to go to glass syringes. Those are the value conflict categories. So we can avoid those altogether. So I would suggest success in 5 years would look like if we can do the no conflict categories, and this is a paper that I'll put the paper link also in the chat. If we can do this no conflict categories right away and work on the context dependent category and stop arguing about the value conflict categories, right? Because there's a clear conflict. And I think it's the path forward that we can all work together on.
Thank you, Dr. Singh. Just in the spirit of time, I'll turn quickly over to Rachel. What does success look like for you in 10 years from now?
Well, in 10 years from now, for me, success would look like something where circular practices are no longer pilot projects or isolated initiatives, but really embedded across the supply chain with measurable economic, environmental, and social benefits, embedding that system sustainability into circular levers. So remember, just because something is circular does not necessarily mean it's sustainable. So benchmarking and measuring across both and with each other. We have regulatory frameworks that are clear and more consistent, and end markets for recycled materials that actually exist and are stable. And we have a broad investment in circular infrastructure that is routine rather than exceptional.
Thank you, Rachel. Jason.
Yeah, I agree with Rachel. I think looking to the future, having those pilots come to fruition into full-blown programs, I think it's going to be essential. Having that market competition to where there's a demand across different solutions on the end market is going to be key to be able to really drive the value of our post-consumer materials and being able to get those to a circular market.
And Ted.
Well, I'll do briefly just to pick up on a thread that was started earlier. In 10 years, if patients were not only asking about what is all this plastic about in healthcare, but that the hospitals could actually tell them about what their progress has been and show that they've actually made progress that is outlined in this report and in the strategy that Dr. Singh has also outlined in his paper.
Thank you. Thank you, Ted, and thank you to all our panelists and to the audience members today for your active participation. A few key themes clearly stand out from this conversation. We're going to need a systems level approach to tackle this complex challenge and to navigate the very many implications of whatever it is that we take between now and the next 5 or 10 years or into the future. And the message is also clear in that circularity in healthcare isn't just about reducing plastics. It's about rethinking systems to improve patient outcomes as well as for communities and the broader planet. As we leave, I'd encourage each of you to take one actionable step in your role, whether that's starting a conversation inside your organization, exploring a pilot that we've talked about, or pressing for standards and procurement changes. So on behalf of Eunomia, Systemic, Healthcare Without Harm, and Practice Greenhealth, thank you all so much for joining us. We look forward to continuing this dialogue and working with you to turn today's insights into tomorrow's impact. Thank you so much.
Thanks, everybody.
Centralized for this.